second part of the what we call the electrical conduction. So from SA node it goes to the AV node. So AV node is like our gatekeeper, is between the atrial and ventricle. So the atrioventricular nodes basically had is special nodes that have been there's some delay in the AV node, so that not all the impulse from the atrial goes direct to the ventricle. So especially it's important in patient with AT, patient with flutter, or patient with fast AF, because the AV node will be the part of the gatekeeper. But in the AV node disease, it can be presented in many ways, but the common presentation and that have been reported in the guideline, basically we had three presentation of the AV node disease. Number one is we have first degree heart block, second degree heart block, as well as we got the third degree heart block. So the first degree heart block basically is misnomer. Basically, it's just a normal physiology of AV delay. And the feature of the first degree heart block, you can see that there's a prolonged PR interval. So usually the PR interval will be more than 200 milliseconds. And bear in your mind that in the first degree heart block, it must be the one-to-one AV conduction. No misbeat in the first degree heart block. And of course, it can be variable, it can be due to the ischemia related, like inferior MI, or it can be seen in the just a healthy children or athlete. So just remember that first degree, no, there's no any misbeat. And the prognosis usually is good in the absence of structural heart disease, and progression to the high degree block is very uncommon in first degree heart block. Okay, then we move to the second degree AV block. So second degree AV block is type 1. We have divided into two groups. Type 1 is and type 2. So basically the type 1 is a waking bed, or we call group beating. So what the main feature of the second degree morbid type 1, here we can see that there is a progressive delay. So we can say the PR interval, there's a prolongation of the PR interval until there is a P wave without the QRS complex. This one what we call the drop beat. And then this one what we call the group beating or waking bed. And then we usually, and it must be the PR interval after block impulse always shorten. It's like a cycle again. So prolongation of the PR interval, drop beat, and it start the cycle again. This one what we call the group beating or waking bed. This is a feature of the morbid type 1. So where is the deletion? So basically in the first degree heart block, second degree heart block morbid type 1 is occur at the AV node site, but it still can be a part of the normal physiology in the normal population. And the nodal AV block has a benign cause, and the risk, like I said before, the risk of progression to the type 2 or the higher degree of the AV block is low. So in this kind of patient, whenever you had patient who came with first degree heart block, second degree heart block type 1, most of them will be asymptomatic. But if the patient complain of symptomatic of first degree or second degree heart block, they need a further evaluation whether it's need an implant or not. Then we go to the second degree heart block, morbid type 2. So what makes different the morbid type 2 with the morbid type 1? We can say the PR interval is constant. There's not any prolongation of PR interval, and after the constant PR interval across the rhythm, there's a drop beat, and then it's not followed by the QRS complex. So it can occur either 3 to 1, 4 to 1, and there's not any prolongation of the PR interval before the drop beat. So it indicate the deletion will be infranodal, meaning after the AV nodes, rather than occur at the AV node nodal area. And the third one is third degree heart block. Here you can see that it's totally disassociated between the atrial and also the ventricle. And here we can see that the P wave is everywhere. There's not they do not talking to each other, and the QRS complex depends where the escape. If the escape occur at the junctional, so we got the what we call the narrow QRS complex. But if the escape occur lower to the ventricle area, you get what we call the wider or the wide QRS complex rather than narrow QRS complex. This usually in a patient with more linear one or more symptomatic, usually the escape rhythm is occur at the ventricle escape rhythm rather than the higher junctional area. Okay, so what is the lesion? Okay, in the AV node, you must know that it's in front. It can be nodal block, or in front of the block, or it can be infrahesion. So in the high degree block like morbid type 2, third degree heart block, the lesion commonly most of the time will be in front of the, it means that below the avinodal block, avinodal lesion. So will be in front of the or distal conduction lesion. It can be any part of the below the avinode. It can be his bundle, it can be left bundle branch block, it can be up to the Purkinje or distal conductor pathway. And before I go to the case presentation, the benign one is first degree and second degree morbid type 1, waking bad, but the malignant one, the most important, causing the symptom or causing the symptomatic avinodal disease in front of the lesion. Okay, so we go to the last case illustration. So we had case number 4, 71 years old male pensioner, very active, still running over the weekend, sometime in the evening, and recently had started to complain of exertional symptom. Then they had done investigation at the private hospital. They had done MSCT cardiac, turned out to be normal. Echo is also normal, and all the blood investigation, everything is okay. So they had referred to us for further evaluation, because if instead everything is okay, but patient still complain reducing reduced effort tolerance during the exertion. So this is ECG that have been done during the clinic visit. Like it's quite a normal ECG, except you can see that the PR interval is prolonged. It's more than 200 beats per minute, 200 milli per second. So okay, so you got the elevation existent symptom with the first degree heart block. So we have proceed with the Holter. So from the Holter, you can see that basically it's quite a normal Holter over 24 hours. They show the waking back second degree epi block. The few occasions that have been noted during the Holter monitoring. First is occur at the 8:40 a.m. in the morning, and the second one is 5 o'clock in the morning. So it's just a second degree morbid 1 waking back, no symptom during the event, during the Holter monitoring. So what else? You had done the echo, you had done the MSCT, you had done the Holter monitoring. Nothing that have been malignant, or nothing the what you call the most troublesome that warrant pressure for permanent pacemaker. So do you want to go for the Holter in the longer, 72 hours or 1 week? Implant the loop recorder, go for stress test, or just reassure it's part of the aging process only, because patient almost 71 years old. So we go for stress test, because the most important thing from the history is that the symptom will occur during the exertion, during the exercise. So this is ECG that will be done upon the treadmill exercise testing. Now we can see that. Okay, I record again. Number 1 is you got at rise, you got first degree heart block, and then during the Holter monitoring you get the second degree morbid type 1, and then during the treadmill exercise testing you can see that goes to the high degree epi block. So we got type second degree type 2 epi block. So we call the drop beat. After 2 beats it drops, and then now you got 3 to 1 blocks, 4 to 1 blocks, and during the exercise testing, patient did complain there's a reduced effort tolerance. They have complained of dyspnea and so mild dizziness during the exercise testing. So the drop beat during the treadmill exercise testing. So do patient need implant or not? So we can see that from the low degree of avinode disease suggested of nodal block, like first degree, second degree waking back. Now when you exercise this patient, stress out the patient, we can see that it goes to the high degree block. Yeah. Okay, so based on the recommendation, any patient, so a bit different from the acinode disease. For avinode disease, whenever you had the second degree type 2 avinode block, or high degree avinode block, or third degree, whether you had symptom or not, patient need for permanent pacemaker. And for our patient, so we get patient 71 years old with exertional symptom, complaint of chest pain, or any symptom that suggested of the asthma symptom like shortness of breath or chest pain, who had the first degree heart block or second degree working back every block, treadmill exercise will be warranted because you want to know whether it's a every node block or in front of the block, because that the indicator whether the patient warrant for the permanent pacemaker or not. Okay. Again, we start to the to the end. Patient, after discuss the patient, we need for conventional pacemaker, we want to implant dual chamber pacemaker for him, and then he said he don't want because if the symptom only occur during the exercise, and they refuse for conventional pacemaker. And is there any other option that we available for him? Okay. So in this patient, we had consult patient for the micra implantation. Micra implantation is micra have been here about 4 years already. Started in micra VR in 2018, and the latest one 2020 we got the micra AV implantation. So this one the micra have been implanted to this patient. It's very good in patient, especially in the elderly patients or patient with high risk for the infection. So we implant the micra for him. Okay. So how big is micra? You can compare with the size. So you can say that it's like a pill. It's very small, and then the size about our 50 cents. And the procedure to implant is more faster compared to our conventional pacemaker, where you need to incision, put the implant, put the wire. Except for the micra, you just need one puncture from the femoral, and then we implant to the RB septal or RB apex. So take home mission for my presentation, basically you can have any type of bradycardia. You can have it, but the bradycardia can be physiologic or it can be pathological. So especially in the patient with the SNO disease, whenever you have sinus pulse, try to correlate whether the pulse or the symptom is related to each other or not. And then always correlate the clinical evidence with the symptom, and try to rule out all the reversible cause, because sometimes you might miss the simple thing like electrolyte imbalance. Sometimes patient may present with dizziness, probably due to the vasovagal, or can be due to the like hypoglycemia. With that, I end my presentation, and thank you.